Good afternoon, everybody. My name is Jen Van Sciver. Welcome to North Ottawa Community Health System's South Beacon campus. We're excited to show off this new community space that we just had renovated a few months ago, back in the summertime. Of course, it doesn't feel like summer today, does it?
No.
We wanted to welcome you here to hold your Kiwanis meeting. We're very grateful to have your time this afternoon. My friends, Dr. Tom Alguire and Colleen VanPutten from Hospice of North Ottawa Community, which is an affiliate of our health system here locally in Grand Haven, are here to present to you some wonderful information that we hope you're going to find of great benefit. This presentation here today for Kiwanis is part of an ongoing series that we kicked off just before the holiday in December of 2013 that's going to run all the way through the spring of 2014 in an effort to help educate the community about hospice services. Not so much in particular what we do, but in general what hospice means to the communities that they serve. What we have found is that there's a lot of information, a lot of misinformation that people have about what hospice can do for patients, and more important, what hospice can do to support the families of the patients that we serve. And so we've embarked in an educational effort, as I've mentioned, over the next few months to help change that and to help rise the level of acknowledgement and awareness in our community about the fine work that's being done with hospice services all across the country, and most certainly with the wonderful work, the very personal and passionate work that's done in the community that we all live in here in Grand Haven. So thank you again, Kiwanis, for hosting us here today, and we hope you find information of good value. So with that, I'm going to turn it over to my friends, Dr. Alguire and Colleen VanPutten.
Thank you, Jen.
Mm-hmm.
Hi, I'm Colleen VanPutten, and I'm clinical liaison and educator for Hospice of North Ottawa Community. And like Jen said, we're located here. We have our offices here at South Beacon. We also have an 8-bed hospice facility out at Heartwood Lodge in Spring Lake. So we are your Tri-Cities hospice. All the members of our staff are your friends and neighbors in the community. Did you know that we've been in existence over 30 years? And we're actually the longest standing hospice on the lakeshore. So we've been around a lot longer, I think, than people realize. So what do? We serve anyone who has a life-limiting illness, someone who has a diagnosis of 6 months or less to live. We serve people wherever they live, be it their private home, a skilled living facility, assisted living facility, out at our hospice unit, and we actually serve patients at the hospital also. So did you know that there is a Medicare and a Medicaid hospice benefit? And hospice is also covered under many private insurances. So what do you get for this care? First of all, you get the services of a nurse, social worker, a hospice aide, volunteer, chaplain, or a nurse practitioner, all coming to your home. You also get the service of Dr. Alguire, and he actually makes house calls. And that's rare to find these days. You get equipment brought in that might be needed at end of life, be it a hospital bed, oxygen, walker, wheelchair, commode. We also provide any sort of personal care items you might need, like briefs or gloves, that sort of thing. And we also cover anything that any meds that pertain to the hospice diagnosis. So I think it's an amazing service, and a lot of people, like I said, aren't aware that we cover all this. So what else do you get from hospice? You get the gift of time. Time for your loved one to feel better. Our staff are experts in pain and symptom management, so once we come on board, we often make the patient feel better than they did before we came on board. Time for your loved one to spend doing what they would like to do at end of life. Time for someone else to take care of and help manage the tough decisions. I know some of my social workers have said that once they sit down with a patient and family and they hear all the services that we cover, they express visible relief. So it's time for someone else to order medications, get in equipment, help with insurance forms, and again, help with the tough decisions that come up at end of life. And I think that this is a really valuable service. So call. You know, we have a nurse that answers the phone 24/7. And no question is too silly. We can always send a nurse to do an evaluation. We can send a nurse or a social worker to do an information session. And you know what, if hospice isn't appropriate at the time that you call, we can help guide you to some other resources that might be more appropriate. And I'm increasingly frustrated because I'm finding more and more that people aren't taking advantage of our services till the last few days or weeks of their loved one's life. And I'd like to illustrate to you that there's so much more that we can do if you call us sooner. I'd like to share a few stories with you. I started out as a hospice nurse out in the field, and I worked outside Washington, D.C. with a large hospice organization out there. And the people that I cared for and the stories that I learned from caring for these people helped shape me and my core values. And I know that my staff here feels the same way. So what are some of these core values? The first is that we counsel. I'd like to tell you a story. I went to see a new admission, and I went in the home. The patient was sitting on the sofa, and her spouse was in a chair. And as I started talking to him, he had all these big plans. He wanted to put like a stairmaster on the stairway and renovate the bathroom to make it more user-friendly for her. But as he's telling me all that he wanted to do, I had my eye on her, and I really didn't think that she would live long enough for him to do all this remodeling. So I did a quick assessment of the patient, and then I took him in the other room and sat down with him. I called our social worker in, and we let him know that we didn't think that she had much time. So we arranged for his grown children to come visit, and I then called our equipment company, got a hospital bed in, got oxygen, other supplies that she needed. I called our medical director and got some meds in to make her more comfortable. And later he expressed to me such gratitude that someone had come into his home and let him know just what was going on. And the whole hospice team rallied together to provide care. Another thing we do is provide comfort. I also did pediatric hospice work. And I remember one little patient, a little 6-year-old boy, who was dying of leukemia. And when we first got involved, he had a lot of pain, so we got his pain under control. And shortly after that, this little boy started to see either visions or hallucinations. He would be in his hospital bed and kind of looking at the wall, and he would be talking to someone that no one else could see. And when his parents asked him about who he was talking to, he would say either Santa Claus or Jesus. And at first this was really disturbing to his parents, because we couldn't see anything there. But working with the hospice team, we got the parents to see that this was comforting to this little boy. And you know what? It became comforting to the parents. And they later expressed such gratitude that we helped them through this. And we never told that little boy that we didn't see what he was seeing. We let him tell us what he saw and acknowledge that. We also provide care. I had another patient, a young man with metastatic melanoma, and the way that manifested itself were wounds all down his lower extremities. So when we first got involved, he had a lot of pain, and we got his pain under control. But along with all those wounds, there was a terrible odor. And the one thing that he wanted to do at end of life was spend time with his coworkers and his friends and family. He couldn't leave the house, so they would have to come in, and he was so embarrassed by the smell. So working with my hospice medical director, we took care of the pain with the wounds and neutralized the smell. And he was so grateful. And his parents expressed to me later that they were really grateful, that he could do what he wanted to do at end of life. And as I mentioned earlier, we give the gift of time. Time for someone to do what they would like to do. I had another patient. She was a middle-aged woman with metastatic breast cancer. And she had really wanted to go overseas. She had spent a lot of time in Australia and wanted to take one more trip over there at end of life. Again, she had a lot of pain, so we got her pain managed, and we actually set her up with a little pain pump. And talking to her, she wanted to make this trip more than anything, and she had the funds to do this. So we arranged for her to take that little pump out of the country. We got scripts, got meds filled, a lot of opioids, and this was post 9/11 outside Washington, D.C. So it was really hard to get all this stuff through the airport. We set her up with a hospice in Australia, and she was going to go for about a month. Now, she also had a grown son in the area, and he was really conflicted because he wanted his mom to do what she wanted to do, but yet both of them knew that she might not return from this trip. And working with the hospice team, myself, the social worker, our doctor, we had a lot of talks with him. And he decided, you know what, this is what Mom wants to do, so let's have her go. She went, she had a lovely time. She was pretty weak when she came back, and she lived for a few more weeks. So she was able to make it back and spend time with her son. I tell you all these stories to sort of illustrate the wonderful things that hospice can do, and particularly if we get involved when there's more time. Instead of getting the call, we go admit someone, and then within a few days, that person dies. If we get called earlier, then we have time to do these things that people would like at end of life. And like I said, time to make your loved one feel more comfortable. Every patient and journey is unique to us. We never classify anyone by disease, location, sex. Everything is guided by what the patient and family desire. In fact, our whole plan of care is guided by what the patient and family would like at end of life. So we take our lead from you, your loved ones. We're here to serve all of you. And I would just like to make this point that we can be more helpful if you call us sooner. Thank you.
That was very nice.
You act surprised.
I'm not going to go last this time, I'll tell you that. Well, I'm Tom Alguire. I think some of you know me. I've practiced internal medicine here for a while. I've been the medical director of our hospice as long as it's been an official hospice in a Medicare benefit. I think that's close to 23 years. And I'm board certified in hospice and palliative care. And I wanted to talk to you a little bit about palliative care, which sort of extends what we do in hospice. I want to tell you what palliative care is, where it's practiced, and what it and who should have palliative care. And then I want to touch on, does it do any good? I've got some exciting news about that. Well, palliative care, well, first of all, palliative, the word palliative care comes from a Latin word meaning to cloak or cover or protect. And so we sort of protect people from the symptoms of whatever they have. Think of it as treating someone without intent to cure, but to make them feel better. Alleviate suffering is what the CAPC organization, that's the Center for Advancement of Palliative Care, would say. Palliative care is growing rapidly. It reminds me of what hospice was 20 years ago. And their definition of what they do is a little more entailed than what I said. They would say that it's a family and patient-centered organization that tries to anticipate, prevent, and treat suffering. And they do that by the old hospice tenets, actually, which means you treat the whole person. You treat the symptoms, of course, the physical symptoms, but you also have to pay attention to the social, intellectual, spiritual, and aspects of a patient's problems as well. They all have to be treated, or you're not going to get where you want to be. I guess the best way to think of palliative care is think of hospice in patients that aren't terminally ill. They just have a serious illness. Well, where is it practiced? Let me start out historically. It's changing rapidly. But traditionally, it was practiced in the hospital in intensive care units. And if any of you have ever been in an intensive care unit, it's not a very pleasant place. It's busy, it's noisy, they're very sick patients. And if you just are recovering from bypass surgery or some other serious illness and you're expected to move on, it's great. You're there for 2 days. It's hard to sleep there. I said it's busy and it's noisy. And it's perfect for that group of patients. They need intense care to get over whatever crisis they have, and then they move on. The group of patients that doesn't work so well for are patients who have chronic illnesses and repeated admissions. I'm thinking of people with acute respiratory failure that have chronic lung disease, heart failure, and patients with bad heart disease. Those type of patients, they tend to be elderly. They tend to be in and out of hospital ICUs frequently. The treatment options may be a little more vigorous than maybe the patients can withstand, and the outcomes are sort of guarded. Those type of patients tend to take up a lot of ICU time, and it doesn't seem to benefit them, and it's expensive to be in an intensive care unit, as some of you have ever been in one would know. So palliative care started as a group of physicians that dealt with that group of patient. And what they did was, first of all, talk to the patients and the family, trying to find out what their goals were. And then, after a discussion and talking about treatment options, come to a conclusion of what's best for that patient. It may not be the most intense type of care. It may be backing out and looking at the symptoms. And so what happens when we do that? Well, most of the studies have shown that patients and families are happier because somebody has spent more time. That's what they do. They sit down, they explain, and they listen. That's a key thing too. You have to listen to what the family and the patient wants. Then you decide what you're going to do. And when you look at what's happened to those group of patients, you find that on the average, there are 2 days less time spent in an intensive care unit. Patients are happier and more comfortable, and the families are, and there was no change in mortality. So it seemed to be a service that seems to work for everyone. Now that was palliative care a few years ago. Now palliative care has grown, and it's treated not only it's used not only in intensive care units, but you see it in hospitals or in outpatient services, emergency rooms, nursing homes, and out in the community. And so it's sort of a treatment for. It's a way of treating symptoms, preventing suffering in people with chronic illnesses that aren't quite ready for hospice or don't have a terminal diagnosis. Well, that's where it's used. And the last thing I want to talk about is, does it do any good? And I have a wonderful article. We know that it does from our hospice stories. Old hospice work has shown that if you're in hospice, for example, with congestive heart failure, you'll live 3 months longer. That's because the nurses are attentive. They tell the doctor right away that there are changes. You can anticipate things and make changes right away. And so that patient doesn't slide into florid heart failure. They're treated quickly. And it's hard to do through an office without that kind of direct contact. I work in an office as well, and I'm sure you've had this experience of calling an office, leaving a message for the nurse gives it to, the phone person gives it to the nurse puts a note on the doctor's desk, and it goes through 3 people back and forth. And it's fine if you have some simple problem, but if it's more complex, it isn't so fine. And so by passing that and going directly back and forth, we find that we can prevent problems. And as I said, it's documented that people in hospice with heart failure on the average live 3 months longer. Well, let's talk about palliative care. This article, you can all even get a copy of it. This is a landmark article. It was printed 2 years ago. And the study was done to see if palliative care actually does more than just make people feel better. And if it does that was part of the study. There were 5 universities that were participating, and I think they included Harvard and Yale, and I don't remember all of them. But at any rate, it was a high-quality study done on 151 patients that had non-small cell lung cancer that was already metastatic, already spread. These are sick people. And they wanted to see the effect of palliative care. So in one group, they gave them traditional care. The oncologist saw them, they treated them, they did everything that they needed to do. On the other group, the oncologist treated them, did exactly the same thing, but they had a palliative care team. And they measured outcomes, depression, patient well-being, intensive treatment. That meant, were you treated with chemotherapy up to 2 weeks before you died? That would be one of the criteria for treatment that's sort of intense. And on the average, these people are sick, and the average time we would live would be about a year. And what they found at the end of the study was there was less depression in patients that had the palliative care team on board. They were happier. They used the intense treatment less often, and the surprise was they lived 3 months longer. So paying attention to people's symptoms, all the other things that palliative care pays attention to, not only makes people feel better, it makes them live longer. So, you know, sometimes people think they're giving up things when they go into hospice. We hear that all the time. Well, we're giving up. Well, more and more studies are showing we're not giving up things. We're making you comfortable. You can actually live longer. We know you can enjoy yourself better because we make you feel better. And now it's becoming clear that by doing that and paying attention to all the details that we pay attention to, you can live longer as well. So palliative care is kind of an extension of hospice. It's for people who have serious illnesses, but the criteria for hospice is if most people with that condition would only live 6 months. And so that really limits us a little bit. Nobody wants to do that because nobody wants to think that they're not going to live for 6 months. And so that's why we get people 2 days, 3 days. The average time that we have patients in hospice is 2 weeks. The national average is 6. We barely have enough time to get in there. So palliative care is one way that we hope we can get in there sooner, tell people and you know, what we can offer them, make them feel better, and make them live longer. And that's what we're planning to do with our palliative care group. I forgot to mention that that's now a paid Medicare benefit as well. It's a little bit different than hospice, but it's still a benefit that's being paid, and I think we're going to see more and more of this palliative care as time goes on. It's really growing. So I'm getting a wind up, so I think I've talked enough. I didn't know we did that. So I'll stop now, and if there are any questions, I'll be glad to address them. Okay, thank you very much. Yeah, Gary.
Yeah, you know, we have a great hospice organization, but we have a tremendous amount of competition. I mean,
Yeah.
we hear ads from Holland and Muskegon all the time.
That's only part of them.
It's
That's
only
2
part
out of 5.
There's more. What can we tell our patients, the people that we know? I mean, yeah, proximity, obviously, but is there something unique about our hospice palliative program that we can tell people that, hey, you're not going to get that elsewhere?
Well, I think being local is helpful. I see it all the time. We have patients, we're not trying to take over the world. You see billboards from people a long way away, and they think part of their plan is to take. We have been centered in North Ottawa community. We serve this area a little bit into Muskegon, and we think that it's important to have a good response time. That means if you're in a crisis, you need it. In fact, we were out last night. You can be at somebody's bedside in a very short period of time, and I think that's the advantage that we have. We're not trying to expand ourselves. I mean, we have hospices, very good hospices, but they're situated, their nurses are in Grand Rapids, and so your response time. So I think that's what we do. But the other problem, of course, is that when people hear the word hospice, they really don't differentiate one from another. And so it depends on who's signing them up and what hospital they're being discharged from and who directs them. Hopefully our patients will know us because we're in the community. Yes?
To piggyback onto that question, is it important, or why is it important, that this particular organization is connected to a larger continuum of care locally?
Well, I think that I can speak for myself in my practice. I still practice part-time in my office, and I think the continuum is good because I talk to the physicians whose patients are ready or near ready for hospice or palliative care. I see them, and if they're not quite ready, I talk to the physician. I have access to their records, and so I think that continuity is really very important. And I think it makes families feel better when I talk to them and I say, I know your physician, I talk to him, I'm getting back to you. I think they certainly enjoy what we can give them, but they don't like to feel all of a sudden the trap door is dropped and they've lost their primary care doc or somebody there. You don't have to do that. And I make that clear. And so that continuum care makes people much more comfortable. That's a good point.
And I think also the fact that our hospice unit is connected to our care center. We sometimes do have people who are residents at the care center, and then they can remain there at end of life, but sometimes there's some symptoms that are better managed in our hospice wing. So it's a nice, easy transition from them to go from the care center to our hospice wing. I think that's another advantage.
I think so. Yeah.
What effect does the National Health Care Act affects hospice? Because there's a lot of change going on this year.
I don't think there are any changes in
No,
hospice or, no, unless you have some information that I don't. I don't think there are any changes slated for reimbursement and for hospice care.
Maybe, and I don't know if this is related to the Affordable Care Act, but maybe more scrutiny and regulation. It's changing. Hospice, when it started, when you first started, back in the day, wasn't so regulated as it is now.
Well, it wasn't even, it was all volunteer. It
Yes.
wasn't regulated at
Yes,
all.
so-
So we started back in the day when you just went into homes and the very first patient it was all volunteer. There was no payment. You just took care of patients. And I think in 1983, I think it was, when it became a Medicare benefit,
Yep.
then you had to have regulations. You had to have a medical director and that sort of thing. Yes.
Maybe a nice thing to piggyback onto that, Dr. Alguire, might be to explain too, board certification in hospice.
Yeah, I'm
and
board
care.
certified in.
How to manage taking less medication. And that's not something you do on a volunteer basis.
Oh, goodness gracious, yeah. I think one of the chores, when you see somebody where you're trying to treat symptoms, and I'm an internist, and I'm guilty of this too, internists have a hard time discontinuing the meds. We like to pile on. And you see people who aren't doing well, and you look at their medicine list. If I had to take those medicines, I wouldn't do well either. And everyone is well intended, and you don't know where some of them came from. And part of what we do is go through that medicine list and find out what really is important for that patient. And sometimes you can get people feeling a lot better if they just don't have to take meds that aren't important. You have to have a reason for each medicine, a symptom you're trying to manage. And it doesn't mean you stop things that will make people, like for example, congestive heart failure. I think some people have the impression that we give people morphine and walk away and make them. No, we don't do that. We do what you're supposed to do for congestive heart failure: beta blockers, ACE inhibitors, diuretics, all of those things. If those are needed to make people feel better, we do that. If they're on a statin and they're in hospice and they have a life expectancy of 6 months or less, it's probably not important that you have your cholesterol goal, probably because you're losing weight anyway. And there's several other medicines that you can discontinue. So being very, very careful with what medications are being taken, what's important and what isn't, does add to the well-being. Stopping medicine sometimes is a good thing. Anything else? Well, I'm glad that, yes, go ahead,
Well,
Leon.
palliative care is a new term.
Right.
And it sounds like it's something that people would introduce themselves to at an earlier stage
Yes.
than hospice.
Exactly.
How well is that known, and how do you become informed about that, and how do you make that kind of, is it through hospice yet for palliative?
Yes.
Yes.
You can call our office, and then actually we're sending Dr. Alguire out to do a palliative care consult. So by calling our hospice number, we can arrange that.
And sometimes we have some things to add, and sometimes things are pretty well managed, and sometimes patients who we pick up in palliative care sometime down the road may be candidates for hospice. And it's nice to be familiar with patients before they have a crisis. It's nice to talk to the physicians. It's nice to have a network in place so patients feel and families feel a little bit more comfortable. But you're right, it is new, but it's growing fast. For reasons that people feel better, their families do better, they live longer. And so I think it's an important new development. I'm excited to be part of it.
It sounds better.
Well, that's the other thing. Hi, I'm from hospice, and people shut the
Right,
door.
right.
Hi, I'm here with palliative care.
right.
And hey, come on in. I would like to feel better. No, you're absolutely right.
Right.
The word drives people
Yes.
away. I've been told, I think more than once, well, I'd love to have you here and help with grandma, but don't tell her you're from
Yes.
hospice.
Yeah.
Okay. Well, now we're from palliative care. I had to take off my card, but it does say hospice and palliative care. So we should reverse them. And then tape
Right,
out the
right.
hospice part so we don't scare people. This is a good comment.
Did you have a question, Grace?
I wondered, are people ever discharged from hospice or?
Oh,
Yes.
absolutely. Oh, thanks, Grace.
Yes.
Yeah, she's a plant. That was great. We love it. It's perfect.
It is.
She's been here before. Yes, we have. I failed to mention that. Yes, we do have patients, and gosh, I can talk, if you don't mind, a story. If you have enough time for a 3-minute story. We love to tell stories in hospice. That's what we're about. Well, I have more than one, but the most recent was a woman who was 99 years old, actually a mother of a friend of mine, came into hospice after the hospice house, after she'd been in and out of our emergency room in hospice like 7 times in 2 months. Heart failure, and they gave her diuretics, got her too dry, renal failure, pneumonia, had fluid in her lungs, they put in a needle, pulled it out, had a pneumothorax, I mean there was air in there. She was in bed, I could barely hear her. Her family was concerned, of course, and I asked her what her goal was, and she was 99 years old. It was April, her birthday was in July. She said, I want to live to be 100 years old, and I thought, ooh, that's, we can try, but we very slowly, that's the thing, we have time. We very slowly diurese her. If you take your time, you can get old kidneys to work. If you're too fast, you just make it so they don't work. So we finished treating her pneumonia, very carefully diuresed her. She finally got up, out and around, got her out of hospice house. She's living at an assisted care facility where she's up and around in a wheelchair, can get back and forth. But we're having trouble. We're still hanging on to her because we don't want to let go. But quite honestly, we're having a little struggle justifying her being in hospice. But we have had people in similar situations that we have discharged. Hospice graduates. In fact, we did almost kick her out.
Yeah, I know.
We did.
And her family said,
family said,
no,
you can't leave.
we
And
want to keep her in hospice.
So one of our very favorite aides got her a T-shirt that said "Hospice Graduate." she wore it when I went to see her. It was so funny. So yes, we do get people well enough so we can't keep them anymore, and that does happen. We've had that happen more than once. Any other questions? Well, thanks. You've been a great group.
Yes, thank you very much.
Oh my goodness, what a deal to come through this snowstorm. I thought
Yes.
there'd be 1 or 2 people.
Yeah, thank you very
Jen,
much.
maybe. I didn't expect you.
Yes.
So with that concludes our presentation. Thank you for being here. Thank you for your wonderful questions, and thank you for being part of our movement to help educate the community about a very important service. And these folks are very humble, very approachable, very likable folks. This is how they are here, is how they are with their patients, and that's why we're so lucky to have them here in our community. So thank you for being a part of this. And
Thanks.
good afternoon.
Thanks
Thank
very
you.
much.